Thank you all for joining us. This week we're talking about field hospital setup and SARI treatment center setup. We have Dr. Vanessa Naidoo, who works for Emergency Medical Services for the Department of Health here in the Western Cape, South Africa. So welcome to our speakers, welcome to our attendees. We're really excited for all of the information that you guys are going to be able to learn and discuss today. And without further ado, I'll let Dr. Naidoo begin her presentation on field hospital and SARI treatment center setup.
Hi, everyone. As we already said, I'm Dr. Vanessa Naidoo. I'm an emergency physician. I was working with Prof. Wallace for AFAM since the beginning of the year, and since March this year, when the COVID pandemic started to heat up in our country, I've crossed over to emergency medical services and disaster management to help out with the setting up of field hospitals in Cape Town. The reason I have a little bit of experience in that is that before I started my emergency medicine training, I spent quite a few years working for MSF, so Doctors Without Borders, in different countries. So I have worked mainly in war contexts, so Afghanistan, Pakistan, Iraq, Syria, South Sudan. And I have some experience of setting up different types of field hospitals. Having said that, in this very short PowerPoint, I'm not going to be able to tell you exactly how to build a field hospital. You're not going to get that here. I'm just going to share some of my experiences and some of the important considerations. If you can't hear me, please let me know if there's any problems. So I'm just going to go through the slides and then I'll take questions at the end of my presentation. So let's go. Okay. So just a little bit of the context first. I think we're all quite familiar with this graph that talks about how the pandemic's sort of the trend as it goes to the peak and what the capacity of the healthcare system is. So where we are at the moment, when we say that we are in a disaster management situation, what we mean is that our resources are not enough for the patient load that we have, and that we have to take extraordinary measures in order to meet that demand. So the aim being to reduce the spread of the disease, reduce the amount of illness and suffering, and decrease the amount of deaths, and decrease the amount of disruption to the healthcare service. So that is both in hospital and pre-hospital, and pressure on the system, and somehow maintain the background medical system that is needed for the patients with all the chronic medical disease. So in that way, a field hospital, or a repurposed facility, can help to centralize case management. It can simplify things. It can take caseload off the hospitals and often simplify that referral pathway. So I'm going to go through some of the minimal infrastructure sort of requirements that you need to think about, and then a little bit about the care plan. So field hospitals can be developed in a few different environments. And if you look at this diagram, this is in South Sudan, so tent hospital situation, in a refugee camp situation, similar one in another area in South Sudan. This is a military base that was repurposed as a maternity hospital in Afghanistan. This is a basketball court that MSF are currently using in Khayelitsha. They opened just over a week ago, and they started seeing COVID patients there. And this is the Cape Town International Convention Center. This is where we currently have set up and opened our facility this Monday, so we're on day 4. So you'll hear me talk a lot about the Cape Town International Convention Center, but I wouldn't take it as the standard example of a field hospital. What we've managed to achieve here is quite different from what you'd expect in a normal field hospital, but I think the principles remain the same. But I will just share some of our experiences so far there. So in terms of selecting a site, so these are general things that apply to any field hospital and not specifically COVID. So obviously important to consider the political context and security. Security is the first and foremost thing, because if you cannot guarantee the security of your staff and your patients, you are not going to be able to achieve any of your aims in terms of mitigation or reducing the number of patients, and you might actually be doing more harm than good. So land rights. So if you find a site that's suitable, you need to find out who owns that piece of land and is it possible for you to use it. In the same sort of context with the CTICC, the building is owned partly by the Department of Health and partly by a private company. So we had to devise a memorandum of understanding about using the building and what we would do and what we could do and what we couldn't do. So that's usually the case if you're going to use a school, if you're going to use a church or a building, you have to discuss that before you go ahead. And then the social and cultural context, so that will affect the way you design your hospital and the kind of things you need to consider with your patient population. So in Afghanistan, for example, we created a maternity hospital, so we had to pay quite a lot of attention to how we handle that from a cultural context point of view. We built a hospital that was run by women entirely, nurses, cleaners, the plumbers, the electricians, everybody was female, and that was culturally acceptable for that kind of work because maternity is obviously a very sensitive issue. Similarly, environmental things like access to water. You can't run a hospital without water, and I'll chat a little bit about the different sources. And then the size, depending on what your population, the population you're trying to serve, and what your incidence of disease and what kind of admission rates you're expecting. So accessibility, same thing. Your population needs to be able to get to your hospital. Same for your staff. That has to be a safe process, and the transport facilities also have to be available, the referral pathways. So that's very important. You can't put the hospital in a place that nobody can get to. Then if you look at this great picture, this is basically environmental and climate conditions that you have to consider when this might work perfectly well in the dry season when everything's warm and hot. But as soon as the rainy season arrives, you could be sitting in a very different situation. So you have to think about the duration of the project. And are you going to go across seasons? Are you going to go through different sort of environmental conditions that you have to consider? And then we talk about soil and the impact on the environment. So location, in that way, you have to think you need a good flat surface that's on a geographically stable area. And if you're going to start building, that soil needs to be suitable for laying foundation, kind of thing. And then obviously it's good to consider the impact on the environment because every hospital is going to generate a certain amount of pollution, a certain amount of waste, and it has to be, you have to have the mechanisms to deal with that. And in terms of wastewater and that, you have to think about how that's going to impact the local environment. So, like I said, I'm a doctor, and my knowledge and understanding of infrastructure has had to increase in the last few weeks. I've spent my time looking at maps and floor plans more than I have looking at patients. So I've learned a lot, but I'm by no means an expert on any of this. When you talk about a COVID hospital in particular, one of the things that are hugely important is ventilation, and you'll hear people talking about ventilation all the time. So the reason for that is, you probably know, because we have the infection control risk that we have to think about in terms of droplet spread and contact surfaces and foam mites and that. So for the Cape Town Convention Centre and all of the field hospitals that we're building here and our in-hospital facilities, we say a minimum of 6 air changes per second, per hour, sorry. And basically when you talk about ventilation, it refers to two components. So it's the air coming into the building and the air leaving the building. And with that, we think about the rate of ventilation. So the amount of air that's coming in from outside, so clean air, breathable air that's coming from outside. So the amount and the quality, and then the direction of flow. So generally we like air to flow from the clean area to the dirty area and not the other way around. So that's when you hear about things like negative pressure versus positive pressure, where negative pressure environment will keep the contaminated air from going out into a clean area, and positive pressure the other way around. If you want to keep an area clean, generally you want positive pressure in that area. And then the other side of that is the exhaustion of air, so the release of what is the polluted, contaminated air inside the building. How do you get that to flow out in a way that's safe? And there are many different mechanisms for that. So you hear about HEPA filters and sort of hybrid systems that use fans and extraction systems, portable extraction systems, to draw air out of an area in a way that's safe and safe for the people outside as well. So the slide basically, so there's a lot of detail in many of these things. So there's many calculations and numbers, and I'm not going to focus too much on that. So I'll just, like I said, a ventilation rate of 160 liters per second is more for ICU. And yeah, so you have to bear in mind the kind of service that you're trying to provide. Okay, so other things to consider, like I said, water. You can't run a hospital without water. So luckily in Cape Town and most of South Africa, we have municipal piped water that we can get from the tap. But in other locations, you have to look at things like bore water, you can look at trucking, and you have to think about the quality of the water that you're getting. Is it drinkable? What can you do with it? How do you clean? How do you make it usable? Can you, obviously, you need to know how to chlorinate water if it's not safe. So the picture right here shows this is inside the CTICC. We've had to set up sinks, so hand washing being the most important principle of our IPC. This is our doffing area. So being a conference center, there aren't too many sinks all over the place, so we've had to create hand washing points. So where that's possible, that's great, but hand washing points can also be as simple as a drum with a bucket if you have safe, clean water in that area. Sanitation, again, important consideration. So in one way for patient and toilets and showers, and then from the other side for contaminated water and washing medical equipment, and where does that water go? So in the case of COVID, it's fine for contaminated water to go into a normal sewage system. So you don't want it going just generally into the environment or onto grass or something like that. It should go into a sewer system, or it should go, or you should have it tanked out so that it can be taken to a sewer system if you don't have direct access. So at the CTICC, we have a combination of those. We have patient toilets that are inside the building, that were built toilets inside. And then we've had to create showers outside. So this picture, it makes me laugh. It's actually the showers that were installed in CTICC. So knowing that it's a conference center, it's not designed to be in a hospital, there are no showers, and it's quite difficult to find a place to install showers. So we made the decision that we would have these portable showers outside the building. So they put up marquees and they brought these in. But when we made that decision, we had no idea what we were going to get. So if you look at the shower, you have to be, number one, quite skinny to fit through the door, and also quite fit to get up the stairs. So we use it as a discharge test. If you can climb the stairs and have a shower, you can probably go home. So as much as you plan, things might not always turn out the way it's expected, and you have to have contingency plans for that. So that comes back to water and how you're going to manage that. So inside we have the capacity to do bed baths. We have very few I suppose I should say, CTICC is planned for 862 patients, so it's a very large facility. And with that, we only have 2 hot water points inside. So if we want to do bed baths and clean patients in their beds, the logistics of transporting water from one area to another becomes a problem. Then other important infrastructure consideration would be electricity. So again, we're lucky to have electricity from local supply, power supply, but also very difficult to run a hospital without electricity. So in most field hospitals, my experience with MSF, we use generators, and they're diesel powered generators. And most of medical equipment comes with a UPS uninterruptible power supply backup. At the facility now, we have the power supply and we have a backup generator, which on a normal functioning of the conference center can provide about 16 hours of backup power, but we expect that to be much less with a hospital environment. And then healthcare risk waste, that's also something that will be foreign to the environment that you are create a hospital in, and you have to have a plan for how you're going to manage that, whether you're going to have a waste treatment area. With COVID, we have made the decision to treat everything that comes out of the COVID area as contaminated. So all medical supplies, equipment, and body fluids and that kind of thing that would normally be biologically hazardous waste, including things like paper and food waste, we're managing as healthcare risk waste. Then fire is an consideration for infrastructure in the way you design your building, because you have to think about what should happen if you had to evacuate the building, what your evacuation routes would be. Is the building safe? Especially with hospitals, we need COVID, especially we need a lot of oxygen. So that's an important consideration. Oxygen is probably the biggest limiting factor, I think, that we're going to get to. So going off the infrastructure a little bit. So oxygen supply, I think we're all familiar with cylinders. We have a few different options. So the cylinders are the one way. This is a picture of the current MSF hospital in Khayelitsha, and they've decided to use oxygen concentrators. So these are very easy to use in that they're portable and they don't need to be refilled, but you need a constant power supply in order to run a concentrator. So these concentrators can run up to 10 liters per minute. We're finding that's not sufficient for most of the COVID patients in the acute phase. So you need 2 concentrators for 1 patient, and that's causing quite a lot of problems. In terms of the cylinders for one can be difficult to find, and the size of the cylinder will determine how long you can use it for, so they need to be refilled. So we worked out with a very large cylinder that's almost as tall as I am. You can run that, we can run 4 patients on 15 liters for about 2 hours, and then it needs to be changed. So the oxygen supply that you choose will have an impact on your infrastructure. You'll have to have storage space if you choose cylinders, or in this picture, you see this is a picture of a bulk tank. So this is what we're using at the CTICC, that we have the luxury of the space and the infrastructure to be able to install a tank. But what that means is you need to install the reticulation to get the oxygen into the building. So this is a picture of the inside of the building, and if you can see, there are little pipes running along the top here, and each one of those pipes now has a little T-piece that comes down, and that's where your oxygen flow meter connects. So in terms of infrastructure, we had to put up these partitions, one for IPC reasons, but also it helped us to put in the oxygen infrastructure. So the WHO has their oxygen resources and distribution guidelines, talks about similar things: cylinders, concentrators, liquid oxygen tanks, and then oxygen plants, which would be a large oxygen generating system that you would have on you. Often not going to be the case in a field hospital. That's not going to be a long-term facility. So cost is generally the thing that will determine what you're able to do, and availability of resources. Concentrators are probably used more than anything else in all the field hospitals I've worked in, especially war context kind of hospitals with bomb blasts, and that you don't want to have oxygen cylinders because that increases the risk. Okay, so going a bit off the infrastructure, but to the design of the building and how you turn any space from an empty building into a hospital, and with COVID in mind specifically. I'm just going to use CTICC as an example. So if we go through this diagram, this is the inside floor space. Look at this rectangular area. These bright blue lines represent the beds. So the line down will be that partition with the oxygen, and then you have a bed on either side. So important considerations we had to make would be, so from the infrastructure point of view, say fire, so these red lines are all the fire exits that lead to the main doors. So that determines how we line the beds and distribute them and where the passages will be. Very important also the IPCs. When we talk about flow, things to move from the clean area into the dirty area and not the other way around if at all possible. So we have a very small clean area, which is this yellow strip down here, and doffing area, which is mildly contaminated. So in our clean area, we have the donning room where you come and you put your PPE on. We have a bulk store. So the majority of our supplies come from offsite, so we're affiliated with a local hospital. And that's something to consider when you're thinking about how to integrate your facility into the healthcare system. So if you are working within the existing healthcare system, it's often useful to be affiliated with a facility that can help you with supplies and to sort of tap into the existing system for referral pathways and for provision of medication, which we've done in this case. So we have a store, but we can maybe store about 2 weeks supply of consumables here, and then we have to reorder and get resupply. So thing for linen, I'll talk about that a little bit with waste management, and then pharmacy. So we have the luxury of having our pharmacy remote because we have a hospital quite nearby that can supply us with medication. And so we have quite a bit of ward stock inside the building in each of the wards, but if we need anything else to come in, we have to send the prescriptions to the pharmacy and they will deliver medication to us. If you're unable to do that and need an on-site pharmacy, there are a few things you need to consider when you're setting that up. So ventilation, temperatures, and the sort of humidity conditions that you can store medication on. There are guidelines on that, but it's an important consideration if you want to set up a pharmacy. So in terms of the flow for staff coming in, you come in and you'll go into the donning area and you'll put your PPE on. Chat about PPE a little bit just now. You come out of the donning area and then you go into this area, which is the working space where most people will spend most of their days. So like I said, this is the bed space. Then we've had to put in support pods. So other things that you will need to have in your hospital. So admin working areas, nurses stations and stores that are close to the wards. So in this case, it's a little bit of an extreme case because this is an 800-bed hospital, but obviously if you're looking at a smaller facility, you will still need to have the bed design. You will still need to have the support spaces, but just on a different scale. And so what we've got is we've got admin, we've got a little treatment room that has closed doors so that you can have some privacy, because in this area we have no privacy at all. We don't have curtains because of the disaster situation and it's going to take too long to get up. So we have screens that we can use. Obviously you want to provide patient dignity and you want to give them some sort of privacy, but you have to find the balance with that. So we have to use screens for that. And if you want to do something in private, then we have the treatment rooms. So when we go here, this is the ambulance entrance. So just one here and another one there. We'll talk about the referral pathway in a little while. And this is an outside area. So once you go outside the ambulance, this is a marquee. This is an outside sort of service delivery area. So in here, we've got, these are some of the patient toilets and showers, again, in 2 locations. We've had to put in a little sluice room and support space that goes sort of to the back of the building. And the reason this is here, which you'll see is a very small space and probably a 3-minute walk from this side all the way to the sluice room, maybe even more. But that had to be that way because this is the only point where there is sewer access and drainage. So you have to work around those things. So we have to create a mechanism to be able to take something that needs to go to the sluice room from down here all the way to the sluice. So we have a closed box that we're going to use on a trolley. Other than that, on this picture, you can see what you can't see is in the sort of area. We have the waste management area, and then we have the oxygen tank here, and sort of a little bit further on, we have a body holding area. Those are the main things that happen on the outside. That area is also considered a contaminated area, and you have to be in PPE to work in there. So just a little bit more on the bed planning from a clinical point of view. So the WHO has that wonderful SARI document that tells you in much more detail the numbers and the calculations for building a field hospital or a COVID-specific treatment center. And this picture is from there. So the way they divide cases based on their classification of mild, moderate, critical, and severe, but you should separate those into different areas. So we have a plan to do that at the CTICC when we can. The red blocks would be patients who have high oxygen requirements, but also high nursing requirements. So the number and the type of staff that you have will determine the kind of care you can provide. We are able to provide 15 liters of oxygen, and hopefully when we get more staff, we'll be able to provide a higher level of nursing care. Sorry, I just want to go back. So we've made it in a step down fashion. So high acuity, the yellow would be lower acuity, and the green would be pre-discharge. These beds in the purple we're using as admission beds. So when people come in the ambulance, they go into this admissions area so we can sort out the paperwork. And I've highlighted these in blue because the bed spacing in that area is a little bit wider, so 2.5 meters instead of 2 meters for IPC reasons. And that's where we plan to put our patients with TB. So obviously in the South African context, we have a lot of patients with TB. Other than that, we may have some patients for palliative care, or we definitely will have some patients for palliative care, and we'll try to nurse those and take care of those in a separate area as well. So that's basically the floor plan that we're using. Context, and then this is the South African Department of Health document for PPE. So depending on the level of contamination in the area that you're working in and your level of patient contact, PPE, I think we've gone through this quite a few times, that PPE, the differences and what's safe and what's not. In a COVID-specific environment, especially where there's 850 beds, we've decided to go with the surgical mask, the visor, the goggles, fluid-resistant apron, and N95 masks only for aerosol generating procedures. So that is the standard PPE we're using. But if you have a smaller facility with adequate bed spacing and ventilation, for general patient care, the PPE that you would use would be just be the apron, the surgical mask, and the goggles. And then that goes along with your flow, which you have to have a clean area to don your PPE and a doffing area to move it safely. So there's quite a lot of training that has to go into that for all our staff, so not just medical staff, so supporters and also all the mechanical staff that have to work in the service yard. So PPE is a huge consideration. It's also consideration in terms of having your staff feel safe and want to work in the environment, but also in terms of industrial action and people not wanting to work. Had a few incidents of staff in different areas of medicine feeling unsafe and feeling that they don't have adequate PPE and halting services because of that. So we pay quite close attention to the type of PPE and this PPE supply. So going on with PPE and IPC, so in terms of choosing equipment and finishes and fixtures to put into the facility, you have to think about the fact that you're going to have to clean those and you're going to have to maintain and repair. So the WHO again gives some guidance on the kind of things that you should consider. So it should be cleanable, easy to maintain, then antimicrobial, non-porous. So with it cleaning, so general cleaning and disinfection, most surfaces and equipment you'll clean with soap and water and then have to disinfect with an alcohol solution, so either 70% alcohol or bleach or chlorine. And there are lots of guidelines for the mixing of those. So use chlorine, 5,000 parts per million, I think. And then you have to have a protocol for cleaning your biomedical equipment. So if you're using oxygen concentrators, you're using monitoring equipment, blood pressure cuff and that, you have to know how you're going to clean those. So most of those things will also need disinfection with alcohol or chlorine. And then staff have to be trained in dealing with body fluids, so how to clean up blood from the floor, how to mop with sputum. And that's something that all staff need to be able to do so that if something happens, the nearest person can deal with that. So body fluids, generally we mop up with paper as much as you can and then go through the normal cleaning process. So the trolleys and the transport I've put in because it's quite an interesting concept to think about, because most of the things in the hospital have to come in from one area and then be used and go out into another area. So things like linen will be brought in, and when it goes out, it has to go out in a trolley, but somehow that trolley has to go back into the clean area to fetch it again. Same with food and everything else from the stores. So we've had to figure out a flow pathway for that. So when something comes in and does its job, there has to be a cleaning area for the trolleys and a separate pathway to get those back to where they need it. Just the buckets, the 2-bucket system. So there are some fancy systems available, but just normal 2 buckets and a mop will just fine. Somebody must tell me if I'm going over time, please. In terms of staff, this picture is a little bit of a joke because when we talk about staff, everybody sort of hangs their heads because we don't know where we're going to get all the people to work in this facility. And I think that's a common theme everywhere at the moment with the COVID surge, is that it's difficult to find an additional staff complement. In our case, to service 800 beds, but at the moment, we've opened 64 beds and we're struggling to staff that even. So it takes everybody who would work in a normal hospital and probably a few more to run a field hospital. And you realize very quickly how important every function is. If, in this case, the doctors are not, I think, as essential in COVID management. The management is quite straightforward, but the nursing care side, the cleaners are incredibly important, and all of the administration that goes with it. So, like I said earlier about staff dissatisfaction and working for you have to pay close attention to occupational health and safety and how you manage that, because we expect that staff are going to get sick at some point. People may contract COVID, and that will affect both our workforce, but also the kind of support that we need to be able to provide them. In terms of hours, working in PPE is quite difficult. So in our case, we've kept it shifts to 12 hours. Going to the bathroom in PPE is pretty much impossible. So we encouraged our staff to use their breaks every 4 hours to go to the bathroom and to avoid drinking on the floor, which is a very difficult environment to work in. So psychosocial support becomes incredibly important for staff. And it's something that can't be overlooked because it's a difficult environment to work in because you have to be in PPE all the time. But people have a lot of concerns about contracting a disease, about taking it home to their family. They may have family members who are sick. So there are many things to consider. And as important as it is to increase the number of beds and provide a clinical service, I think we have to take care of each other. So just think about that. Getting a bit to the clinical side, there's a big question mark here because we started out with great ideas about admission criteria, and we in the first 4 days realizing that the situation might be quite different from what we anticipated, that if the system is overloaded, most of the patients with COVID are quite sick, and the idea of having a stable mobile patient who needs inpatient treatment is not quite working, so we have to work around that. So in any field hospital situation, it will depend on what the demand is, what your hospitals need in terms of getting referrals out, and what service you're able to provide with what you have. So do you have the oxygen? Do you have the staff to do what is needed? So at the moment, we're looking at having to adjust our systems to take care of patients who have more mobility problems, which again brings me back to the showers, which are not very practical. So there has to be a lot of flexibility built into the system because you won't really know how it's going to work until you start. So you have to be able to start with a plan and change as you go. And we expect that as the COVID surge hits and as we get more patients, that the patient profile will change and we'll have to adjust again. And it will probably decrease at some point and then we'll have to adjust again. So that's part of the process of running a field hospital. So the clinical care I'm not going to go too much into. So we're doing a pretty standard package of care, oxygen, IV empiric antibiotics for severe cases, physiotherapy. We're giving thromboprophylaxis to severe cases as well. In terms of clinical support services, we have access to radiology, so X-rays, which is not essential, but because of the number of patients, we decided that was useful and we had access to it. We do have access to X-ray and ultrasound. And like I said, the remote pharmacy and physiotherapy, and then social services for both our staff and our patients. Because not everybody can go home straight after being in hospital, and that will be the case everywhere. People need help to get into isolation facilities or deal with the social impacts on their families and have assistance before they go home and are discharged. This is just our referral pathway. So I'm focusing a lot on the CTICC story because I'm so deeply involved with it at the moment, but I hope you can see the principles. So like I said, integrating a facility into the current healthcare system would be important if you want to provide relief to that system. So you're using the same referral pathway that most hospitals would use. So a physician will contact another physician and discuss the patient and then arrange transport and the patient will come across. And then as things get, as the patient load increases, we imagine that we'll get to a state where even with the field hospital, we might not have enough beds. And then we have to have a plan for what we're going to do in that situation. That is where a lot of the ethics come into play and the difficult decisions about what we're going to do at that point. Okay. So that's a little bit of the basic background from a field hospital perspective. I think, like I said, CTICC is not a normal field hospital in any way. But if you think that this is how it started, it's just an empty space. And now we're actually able to treat patients in that space. And within less than 3 months, we've been able to convert it into some sort of hospital. So in our context, fortunately, we were able to get hospital beds to build this hospital. If we need to open more beds, that might not be the case. So we might have to change strategy to go to not using hospital beds anymore, so to use prefabricated structures or cardboard beds that are put together. And that's the kind of flexibility you need to have in a disaster situation to be able to do that. So this level might not be possible for everyone, but it's completely adjustable. And if we have to do that, then we will. And yeah, so that's basically where we are today. Beds, just no patients. So we're hoping to ramp up in the next couple of weeks and to get more staff and to get more experience in dealing with this. Thank you very much.
Thank you so much, Dr. Naidoo. I think that was an incredibly informative presentation, and it's really cool to see the CTICC story and just understand the resourcefulness that goes into creating a field hospital. So I'm sure that that's incredibly relevant for our attendees. And it doesn't look like we have any questions. We did provide a couple of links related to the WHO throughout your presentation, and your presentation was incredibly comprehensive. So I think people are just absorbing everything that you've provided us. So thank you so much for taking the time and walking us through what goes into creating a field hospital in the COVID-19 pandemic.